Both column fracture through the extended iliofemoral approach. To perform the extended iliofemoral approach, the patient is placed in the lateral position, usually on the Judet extension table. The specimen represents a right hip. The foot of the patient is to the left. The head is to the right. The surgeon stands in front of the patient. The tensor fasciae latae and gluteal muscles are reflected posteriorly from the lateral aspect of the iliac wing. The greater sciatic notch is exposed, and the tip of a retractor placed into it. The lesser sciatic notch is also exposed and utilized as a place for a retractor. The external aspect of the innominate bone has now been exposed. The exposure includes the superior part of the ischial tuberosity, the retroacetabular surface, and the external aspect of the iliac wing. The superior and posterior aspect of the hip capsule is also exposed. The hip capsule can be opened just distal to the acetabular labrum. Further exposure of the anterior column and hip capsule can be obtained by detachment of the reflected and direct heads of the rectus femoris from the bone. To give further exposure of the upper portion of the anterior column, the sartorius and inguinal ligament are detached from the anterior superior iliac spine. The abdominal muscles and iliacus are detached from the iliac crest, and the iliacus elevated from the internal iliac fossa. A retractor is placed with the tip over the pelvic brim. The anterior column is now exposed distally to the pectineal eminence. For this exercise, we will use part of the 3.5 millimeter instrument set and this selection of the 4.5 set. These are the instruments used for the insertion of the 6 millimeter shunt screw. Also needed, this pelvic reduction forceps used with screws in combination with the Farabeuf clamp and normal reduction forceps. The fragments are held in place with the small oblique pelvic reduction forceps and the bone-holding rod, both with pointed ball tips. The template serves as a model for bending the plate with the bending pliers for reconstruction plates and the bending iron. Position the pelvis in the vise as if the patient were in the lateral position. This both-column fracture includes a triangular fragment of the iliac crest, a high anterior column fracture line, a separate fragment of the posterior wall, and a posterior column fracture crossing the greater notch. As is typical for a both-column fracture, the three articular segments of the anterior column, posterior wall, and posterior column remain attached to the hip capsule. These three articular segments are displaced medially and completely detach the articular surface from the remaining intact portion of the iliac wing. The fracture reconstruction is built on this intact portion of the iliac wing. Exact planning is important, so as not to block the single steps. By reduction with clamps, the later lag screw and plate fixation have to be taken into consideration. Reduce the triangular portion of the iliac crest to the intact ilium with a Farabeuf clamp. Hold the reduction with the pointed reduction forceps, and then remove the Farabeuf clamp. This fragment is fixed with a 3.5 millimeter cortical screw, which parallels the crest. Drill a gliding hole with the 3.5 millimeter drill bit. Use the 2.5 millimeter drill bit for the threaded hole in the intact iliac wing. Measure the depth and insert the 3.5 millimeter cortical screw. In acetabulum fracture surgery, the motor is routinely used for insertion of the longer screws. This not only saves time, but also better preserves the hexagonal recess of the screw head over the many revolutions that must be applied. Final tightening takes place with the hand screwdriver. Two 4.5 millimeter cortical screws are placed for reduction of the anterior column fracture. Their length will be 10 millimeters longer than the measured depth. They are placed just opposite to each other in the intact iliac wing and anterior column, and just cephalad to the point of later lag screw fixation. They must be placed so that they are parallel following the reduction, otherwise the pelvic reduction forceps will impede the reduction. The screws should not be tightened too firmly. Grasp the anterior border of the bone with the Farabuff clamp. The Farabuff clamp controls rotation of the anterior column, while the pelvic reduction forceps control displacement. Look at the reduction along the iliac crest to ensure that the rotation of the anterior column is correct. The anterior column is externally rotated. Now it's reduced. The pointed reduction forceps hold the reduction along the iliac crest. The lower part of the reduction can also be maintained with the large angled jaw reduction forceps. Place a 3.5 millimeter cortical lag screw along the iliac crest between the anterior column and the triangular fragment. Place another 3.5 millimeter cortical lag screw from the lateral cortex of the intact ilium to the medial cortex of the anterior column. This lag screw direction is possible because the plane of the anterior column fracture is oblique to the plane of the iliac wing. A 6.5 millimeter shaft screw will now be placed, starting just lateral to the anterior inferior iliac spine and directed just superior to the greater sciatic notch. The tap is used for the plastic bone, but is typically not necessary for screw insertion in the human pelvis. The reduction forceps are removed. However, the screws are left to be available for later steps in the reduction. Another 4.5 millimeter cortical reduction screw is placed into the posterior column anterior and lateral to the ischial spine. To control rotation of the posterior column, a 5 millimeter shunt screw is placed into the subcotyloid groove, just lateral to the superior part of the ischial tuberosity. When the pelvic reduction forceps are applied to the posterior column, the feet should normally point to the greater sciatic notch, preventing excess stretch of the sciatic nerve. If reversed, the sciatic nerve can be stretched around the inferior portion of the forceps. In order to help visualize on the video, the forceps will be placed in what is normally considered to be the wrong orientation. The shunt screw is used to control rotation of the posterior column. The pelvic reduction forceps will control the displacement. The reduction is judged by visualizing the retroacetabular surface as well as the joint surface. The reduction should also be checked by palpating the quadrilateral surface through the greater sciatic notch. A 3.5 mm lag screw will be placed from the intact ilium to the posterior column. By retracting the posterior wall fragment and distracting the femoral head from the acetabulum, the reduction between the anterior and posterior column can be seen along the articular surface. There is very often a cancellous bone defect near the area of the posterior wall fracture. It is usually not necessary to bone graft this area. However, a bone graft can be placed if the posterior wall needs further support. Reduce the posterior wall fragment with pressure from the ball spike. Fix the posterior wall fragment with a 3.5 mm cortical lag screw that starts near the rim of the acetabulum and leaves room for the plate to be placed posterior to it. Take care not to enter the joint with the screw. An 8-hole plate will now bridge the fracture fragments from the inferior portion of the retroacetabular surface, traversing the posterior wall fragment and ending on the iliac surface of the anterior column. The plate will be curved, so that its curve parallels the rim of the acetabulum. The bending template can be used as an aid in shaping the plate if the surgeon prefers. Careful contouring of the plate ensures that the plate will not create a redisplacement of the fracture. Therefore, a straight plate is chosen because it is thinner and contours more easily than a curved plate. A 3.5 mm screw is placed first in one of the end holes of the plate. A screw placed in the opposite end of the plate can place the plate under tension and positively locate its position. It is not necessary to fill all the plate holes with screws. In this case, 2 screws in each end and 1 more screw through the posterior wall fragment will suffice. The fixation is now complete, and we can inspect the reduction on the inside of the joint. The reduction is perfect, except for the lowest part of the anterior column which has not been reduced or fixed. Reduction and fixation would not improve the functional outcome, and would require unnecessary surgical exposure.